Thank you, Roxana. Are you able to see me and hear me with the slides?
Hear you, we see you, you're loud and clear and beautiful on our screen.
Okay, thank you. So what I'm going to talk is, how can we use the newer technology in taking care of patients, especially the acute patient that we come across. So this is the Mission Lifeline strategy where we have for every patient with STEMI that's presenting, the metrics are 45 minutes if they're door in, door out for the transfer. EKG has to be done within 10 minutes of arrival. And if you need to get a plus measure, the door in, door out has to be less than 30 minutes. And we all know for the patient that's presenting in the ED, it's about door to balloon time, EMS or FMC to PCI should be less than 90 minutes. And for transfer should be 120 minutes. Why I'm saying this is, used to be our metrics in 2018, 2019. These were transfer patients. We barely made our threshold of even 75% of the patients who could even meet the metrics for these transfer patients of her there. So it is not just us. So over the years, you have seen there's so many publications for door in, door out. If you see there, not 45 minutes, it's barely close to 60 minutes, even across the country. And FMC to PCI for non-transfer patient also very rarely they were making the timings. So this was presented in 2022 in American Heart Association, where you see 25,000 transfers across in the United States. Only in one quarter, again, only in one quarter, only about 25% of the patients met the goal of meeting 100 and less than 120 minutes for door to balloon time. So even in a country like America, where the healthcare we think is really great, STEMI patients are not getting the care that they really need. And I think just now, Greg presented a danger shock trial, and I just want to show you what was, so if you see there, even the time after the median time from symptom onset to randomization was about 4.8. I know they are cardiogenic shock patients, but we know for over years that from symptom onset to opening the artery definitely did do well in patients' mortality. So everywhere we still need a way to improve the system. So American Heart Association came out in 2020. Can we do pre-hospital activation of hospital resources, take the patient directly from the home into the cath lab? But being interventionalists on call, we know majority of the time, I would say about 30-40% of the time, they're not STEMI, they're in other cases. So there are a lot of false activation. So they did put some criteria where we think if they met the criteria, patients can go directly to the cath lab, avoid ED, so we can save another 25-30 minutes of the ED time. So that's when in 2018, we decided let's have what is called a communication platform. We created an app. So goal was the EMS should have it, but due to the logistics and political issues, it's not that easy to have FDNY to carry this. So we started using this app from the ED to the PCI time. So if you see that 2018, 2019, it took us time to conceptualize it. We were ready, but 2020, due to the pandemic, we were not able to execute it, but we started it in 2021 from Mount Sinai, Queens, and now we are doing it across our health system. What did we see? So if you see here, door in, door out, before the app was about 68 minutes, came down to 52 minutes, we can do better. And device, door to device time after transfer, okay, not 120 minutes, we've actually met to 91 minutes. And if you see here, like I showed you before, we barely hit 75% of our cases, making 90 minutes door to transfer time. But after we use the app, 100% of the patient met less than 120 minutes using that. Now, we also have to make sure that what we have done, did it reflect in patient outcome? So this is ACC NCDR data where you see that in-hospital death due to STEMI is about 2% around the country, and we have about 0.3%, showing that, of course, our improvement in time did reflect in patient outcome. This is a example of a case of a transfer, 3 a.m. in the morning. The activation is very simple. You take the picture of the EKG, and add in the patient name, date of birth, just to be sure it is the right patient. And the call goes directly to the interventional cardiologist. They will review it, have a discussion with the ED physician, by which time our transfer center would have already sent the ambulance to our sister hospital. Then there is a chat that you can get involved with. You can include all the vitals if you want, but our next generation will be in the Epic, so we don't need to use most of the things. But most important is the GPS. So we exactly know where the ambulance is going. Are they picking up the patient? So our transfer center as well as the ambulance is part in the app, and they will also keep updating, and everything is time-stamped. Is that exactly what happened to this patient? So this patient came here, was anterior ST elevation, mid LAD, I think got heparin, Brilinta, and then had a stent. So if you see here, door in to device time was 91 minutes, less than 120 minutes of a transfer patient. I know it was 3 a.m. in the morning, but less than 120 minutes. This was a local case. This was activation happened from our ED. Again, young patient, ST elevation, they activated the app and had LAD PCI in this totally occluded LAD, had a LAD stent. So door to balloon time was about 45 minutes in this particular case. These are the couple of publications. We have presented it in ACC, ESC, and many other places, how this can be used. So currently, I already mentioned what we have. So what are the future updates? I know there have been some discussion by Dr. Harrington and others where we can use AI. So definitely AI can be used for recognition of EKG, conversational AI, where, you know, when you're talking, especially if it goes to the EMS person's hand, that the conversation AI will be integrated, and that is how we can have this tool be used for the next level of work. So the future could be, what we vision would be that a patient has chest pain. There will be a 12-lead EKG that will be can be done with the devices that if the patient has, and automatically will get AI interpretation of the EKG that will alert the nearest interventional cardiologist of the hospital, who can then have a video call with the patient and confirm that, yes, this is a STEMI, by which time the EMS is already in the patient's house and the nearest hospital will have a room ready. The problematic in a big city like this is during the daytime, multiple cases are going on, and having a room ready is not easy, but we have this kind of a communication platform. Patients could be done. And 2025 and beyond is that you will have a wearable, which is either a watch or a band or a ring, where EKG can be done. And when that happens, the patient itself is wearing something, then you have your activation directly to the interventional cardiologist, again, the nearest interventional cardiologist. Just changing gears to say where AI can be used currently in cath lab, especially if you see that we are making pre-procedure calls to talk to the patient. This takes full-time FTE nurses making calls, and so many questions are being answered to the patient. Can we do this using AI?
My name is Sophia, and I'm a virtual assistant calling from Mount Sinai Hospital. May I speak with Andrew Baker?
Yep, that's me.
Great. Working with Dr. Keeney to help to coordinate your upcoming procedure at the Mount Sinai Cath Lab. Before we begin, could you please provide your date of birth, including the year? Please get a pen and a paper so you can note the instructions.
Okay, give me 1 minute.
Sure thing. Just tell me when you're ready.
Okay, I'm good.
You have a cardiac catheterization procedure scheduled with Dr. Keeney tomorrow, June 12th. You should arrive to the hospital at 9 a.m. The hospital, located at 1468 Madison Avenue, which is at the intersection of 100th Street and Madison Avenue.
When do I need to stop eating before the procedure?
So this is a conversation that a patient can have, and we have named this AI bot as a Sophia, so they can talk to Sophia and have a conversation. And if you see there, Sophia, very calm, very nice person, can keep answering the questions. And then what happens? Will not get upset. Keep answering, and you can even ask, do you want to talk to a woman or you want to talk to a male? And keep talking and discussing. So other thing was that when this is done, there will be a report that will be generated, and this will get into the patient's EMR. So most important thing is all this. There are certain red flags, and when that red flag is there, then human will call, which is our nurse will call. So essentially, it is augmenting and helping the nurses to do these phone calls faster. This is what it is: preparing for the procedure, post-discharge instruction, follow-up reminders, medication reminders, and a lot of education, scheduling, and more and more. And this is where AI could be used. And the final slide is our apps that we have created. And the one that we released during our symposium is Device Aid, where we have the entire devices that we use in the cath lab is included in that Device Aid app. And we have reached over 100,000 downloads. Thank you.